Today I will talk on pigmented villonodular synovitis. Pigmented villonodular synovitis is usually seen in 30 to 40 years age group people. Incidence is 2 to 8 cases per million per year in the general population. It is a benign proliferative disease of the synovial joint, synovial bursa and tendon sheath. It is usually monoarticular process. Knee joint being involved most often, followed by the hip, ankle, shoulder and elbow. There are two types, localized type and a diffuse type. Currently, a localized pigmented villonodular synovitis and tenosynovial giant cell tumors are interchangeably used in the literature. Coming to the clinical presentation, localized usually affects hands, knee and ankle. It usually presents with a painless swollen joint. Osseous erosion may be seen. MRI shows a well circumscribed soft tissue mass and recurrence is about 8%. Diffuse form is usually seen in the knee joint in 75% of the time. Joint presents with the swollen joints which are usually painful and tender. Degenerative changes are seen in the joint. MRI shows ill-defined soft tissue mass. Recurrence rate is high, almost 30 to 33%. Histologically, localized form shows mononuclear cells, giant cells, foam cells and hemosiderin deposits. Histology of the diffuse form is infiltrative pattern. Species are filled with the blood. Small histiocytes like cells and larger cells. Small histiocyte cells can be round or spindle shaped. Osteoclastic giant cells are absent or rarely seen in 25% of the cases. Mitotic activity is more than 5 per 10 high power field. Rare reports of malignant transformation is seen. You have to suspect a malignant transformation if there is a necrosis or if there is more than 20 mitotic per high power field, enlargement of the nuclei, abundance of the eosinophilic nuclei and myxoid changes. There are some histological similarities of the pigmented villonodular synovitis with the other tumors. The first one is giant cell tumor of the tendon sheath, but giant cell tumor of tendon sheath is encapsulated and lacks the villonodular architecture. Second one is hemophilic joint. In hemophilia, there will be proliferation of the fibroblasts and vascular cells, but it lacks the giant cells and lipid-laden histiocytes. Coming to the diagnosis, 32% of all PVSs and 54% of the PVS of the knee appear normal on radiograph. In localized form, you can see erosion. In diffuse form, you will see arthritis of the joint. In many instances, advanced imaging such as MRI is obtained to rule out other etiologies. It is the most sensitive imaging study to evaluate pigmented villonodular synovitis. Pigmented villonodular synovitis is one of the few soft tissue processes that has nearly pathognomic appearance on MRI, presenting with a low signal intensity and a blooming artifact. Noticeable signal loss and gradient echo sequences due to the iron in the hemosiderin deposition. That means MRI is a diagnostic test for the pigmented villonodular synovitis. Hemosiderin deposits low signal regions in the T1 and T2 weighted images. Differential diagnosis. Although the combination of physical examination and imaging findings can suggest the diagnosis of a pigmented villonodular synovitis, histological confirmation with a biopsy remains the gold standard. Other diagnoses you should think before coming to the final conclusion are amyloid arthropathy. There is no blooming artifact. Synovial chondromatosis. Multiple mineralized intra-articular bodies are seen here. Synovial hemangioma. Intermediate T1, hyper T2 lobulated intra-articular masses. Synovial lipomatosis. Fatty lobular intra-articular mass absent hemosiderin. Synovial sarcoma. Low intensity on T1 weighted images and high intensity on T2 weighted images. And the last one is infection. Coming to the treatment of PVS. After MRI, you have to do a tissue biopsy. After histological confirmation of a required diagnosis, if it is a localized form, a patient is asymptomatic, no pain or mechanical symptoms or disease progression on a repeat imaging, then you can observe the patient. The patient is symptomatic, like he has got a pain, progressive disease on a repeat imaging, then you have to do surgical excision. You have to begin with a least invasive procedures like arthroscopic partial synovectomy, lesions excision if accessible by arthroscopy, or if symptoms persist or recur after partial synovectomy, then you have to do a open synovectomy. Open lesion excision if it is not amenable to arthroscopy. If it is diffuse form and asymptomatic and stable, no pain, mechanical symptoms or no mechanical symptoms, no pain, no disease progression, repeat imaging, you can observe it. If it is symptomatic, if it is progressive, then you have to do a surgical excision. If it is symptomatic from the beginning, like the patient has got a pain and he has got a mechanical symptoms and disease progressive, then you have to do a surgical excision and you can give a medical therapy. Multiple surgical options recommended beginning with the least invasive procedure. PVNS is a benign proliferative disease of the middle age. Knee joint is most often involved. There are two forms, localized and diffuse. MRI is a diagnostic test. It shows a blooming artifact. Stable asymptomatic lesions require observation. Progressive symptomatic lesion require a surgery.